Is the screen visible?
Shekhar Kanbartuna.
Yeah. Shall we start?
Okay, done.
Okay. This is an extension of the class that was of the last week's class of Ravi, in which he described about all the old classification, Miles Williams classification initially, but that classification has been updated since 2018. So I'm going to take you through the updated classification and what are the drugs that are newly entered the classification, how many classes are there, and their uses and their adverse effects. So coming to the basic cardiac action potential, as you know, there are 5 phases, 0, 1, 2, 3, 4. Where in the 0 phase, there is sodium enters into the cardiac myocyte. At the phase 1, the potassium and chloride comes out. Phase 2, calcium enters in. And phase 3, potassium delayed after depolarization, potassium goes out. And at phase 4, there is a potassium rectifier. So this classification is given by, this is the cardiac cycle, and the old classification was given by Miles Williams, and he studied completely the beta blockers mechanisms and the beta blockers anti-arrhythmic activities, and he updated the world about the beta blockers activity. And along with him, one Indian is there, that is Brahma and Singh. He is a New Zealand physician. He also flew from New Zealand to England to become associated with Miles Williams, and he and Miles Williams developed the old classification, which was there since almost 100 years. So they classified the drugs into 4 major possible classes that are modifying the action of potassium channels, sodium channels, and calcium channel functions, and adrenergic activity. So the class 1 drugs, just a quick recap. The class 1 drugs are again divided into class 1A, 1B, 1C, depending upon the degree of sodium channel blockade. And the sodium channel blockade that occurs in the phase 0. So the 1A is moderate, 1B is weak, and 1C is marked sodium channel blockade. So coming to the class 2, these are beta blockers. They are affecting the phase 4 of the cardiac action potential, and they particularly act on the SA node and the AV node. Coming to class 3, these are potassium channel blockers. They act on the phase 3 in delay after depolarization, delayed the after depolarization, and lengthen the ERT. So for the class 4, these are calcium channel blockers. They act on phase 2, and they also decrease the conduction rate and the heart rate, particularly acting on SA node and AV node.
Both class 3 and 4 are for calcium channels, huh?
No, sir. Class 3 is potassium channels.
Okay, because I heard as calcium.
No, sir. Class 3 is potassium channels. So this is a quick recap of the old classification. Coming to so why this modern classification is derived? This is not a new thing. This was started in 1991 by European Heart Journal. They want to study the molecular mechanisms of all the drugs that are acting on cardiac myocytes, and they conducted a meeting in Sicily, and they called they want to rectify everything, and they want to know everything about the cardiac arrhythmic drugs, and they called it a Sicilian gambit. They named it after the Queen's Gambit in the chess game. So they want to negate all the harmful effects and all the arrhythmias that are that are occurring in the heart with this classification. But this classification was too unpractical because it is successful in one way that it make us understand the molecular mechanisms, but it is not useful for a practical purpose. So they made it obsolete because it is particularly impractical to apply in day-to-day life. So then the modern classification is, they started thinking about the modern classification, and in 2018 they updated the classification. So this contains 8 classes, class 0, class 1 up to class 7. And all the drugs that are used in cardiac patients and for the cardiac arrhythmias are divided into these classes. Some of them are divided into subclasses. It's an extension of Miles-Von-Williams. This is not a new classification. This is just an extension of the Miles-Von-Williams classification. So coming to the class 0, these are HCN channel blockers. These are only one drug is there. They particularly affect the sinus node, and they in phase 4 pacemaker depolarization rate and reducing heart rate, and also decreases the AV node automaticity and Purkinje cell automaticity, and increase the RR intervals. So what is these HCN channels? I will talk about the HCN channels in the at the last. So where the mechanisms I will explain. So this class contains only one drug, that is ivabradine. So it decreases the SA node automaticity. It is particularly useful in stable angina, chronic heart failure with heart rate of more than 70 beats per minute. So the potential new implications for it has the potential to new implications for sinus and tachyarrhythmias. The only drawback is the adverse effect is it might cause sinus bradycardia. Coming to class 1A. Class 1A, as we know, it's sodium channel blockers only, as we see in the old classification. But this class 1A, these channels, sodium channels are this NAV 1.5 channels. They act in open state. So the this time constant is 1 to 10 seconds. These are moderately acting, intermediate acting dissociation kinetics. These contains intermediate acting dissociation kinetics. The time period is only 1 to 10 seconds. And often concomitant potassium channel blockade is also there in some drugs, and it causes the decrease in the peak inflow of sodium and decrease in the action potential generation, and with an increased excitation threshold. So it decreases, it slows the action potential, conduction in the atria, ventricles, and ventricular conduction pathways. So it also decreases the inflow of the potassium and increasing the action potential duration and ERP, and it also increases the QT intervals. By doing this potassium blockade, it also increases the QT intervals. These drugs include quinidine, asmalin, and diazepam. So these drugs, as we know, all these drugs will cause prolonged QT syndrome. So it also decreases how it is helpful. So it decreases the reduction in the ectopic ventricular or atrial automaticity, or decreases the accessory pathway conduction, increases the refractory period, decreases re-entrant tendency. So apart from this, as you see, these individual drugs act on different channels and causes class 1A antagonism also. This class, according and cholinergic and also along with class 1A antagonism, it also acts in all these channels to decrease the heart rate and everything. So it decreases the inflow current of potassium, ATP, calcium, everything. So coming to diazepam, it also decreases the inflow of potassium and ATP, and cholinergic action also, and cholinergic action also in addition to the class 1A antagonism. So the negative inotropic, but no alpha or beta adrenergic effects. There is negative inotropic effect is there, but no alpha or beta adrenergic effects. There will be with this prolonged QT interval, there can be torsitis pointis or vagolytic effects, and increases the ventricular rate in atrial flutter. These are the negative impacts of the class 1A drugs. Coming to class 1B. So these drugs also act in the sodium channels in open state. So, but these are rapid dissociation. These have a rapid dissociation, and these have a less dissociation constant. So the time period is only 0.1 to 1 second, and it acts particularly on inflow of the sodium, and thus decreasing the reduction in the peak sodium entry, decreasing the action potential generation, and increasing the excitation threshold. So it decreases the conduction in the atria, ventricle conduction pathways as we see in the class 1A, and also shortens the action potential duration and ERP. So this can be seen in normal ventricular cells and Purkinje myocytes also. This prolongation of ERP and post-repolarization refractoriness will also occur in this in partially depolarized cells. The main drugs that we see in this is lidocaine and mexiletine. So these are the two drugs, and there will be QT shortening because of these drugs. And coming to the reduction in the main uses are reduction in the ectopic ventricular automaticity, reduction in the delayed after depolarization induced trigger activity. So it doesn't affect on potassium channels, potassium inflow current like class 1A drugs. So the only there is also a tendency of converting the unidirectional to bidirectional block, particularly in ischemic and partially depolarized myocardium. That's it controls, these drugs controls the rate like that. So coming to class 1C, these are slow dissociation blockers. So these act on sodium channels in inactivated state, not in open state like class 1A and class 1B. So there will be reduction in the peak sodium inflow. There is reduction in the action potential generation and increased excitation threshold, slowing the AP conduction same as the other two classes. It also increases the AP conduction, atria, ventricles, and conduction pathways, and reduces overall excitability, prolongs the action potential duration at high heart rates, and increases the QRS duration. The two drugs included in this is propafenone and flecainide. So they causes reduction in the ectopic, ventricular, or atrial automaticity, reduction in delayed after depolarization, induced trigger activity. So reduced re-entrant tendency and converting the unidirectional block to bidirectional block like class 1B. So that slowed, it also causes the slow conduction and reduced excitability, particularly in rapid heart areas, blocking re-entrant pathways, showing depressed conduction. So coming to class 1D, these also acts on sodium channels as the class is sodium channel blockers, but these act in late current. So there will be reduction in late inflow of the sodium current, effective AP action potential recovery, increased refractoriness, increased depolarization reserve, and prolonged QT interval. The drug that is used that is there in this class is ranolazine only. So there will be a decreased action potential recovery time and reduction in early after depolarization induced trigger activity. So coming to class 2. Class 2 is again divided into subclasses. In class 2A, the class 2 is particularly autonomic inhibitors and activators. It's not like beta blockers. It's autonomic inhibitors and activators. So in class 2A, you have non-selective and selective beta adrenergic blockers. They act via G protein coupled mechanism, and they increases the cyclic AMP, and also which affects and slows the SA node pacemaker activity and decreases the inflow of funny current, and decreases the late calcium inflow. Thus, it increases the AV conduction time and refractoriness by decreasing the SA node pacing and triggered activity, and results in reduced inflow of sodium, calcium, and also reduced, because of reduced inflow of calcium, there will be reduced ryanodine receptor type 2 mediated sarcoplasmic reticulum calcium release, and whenever the calcium releases, it triggers activity. So it also decreases the triggered activity caused by the calcium, and also thus it increases the RR intervals and PR intervals. So coming to non-selective beta blockers, you have carvedilol, propranolol, and nadolol. And beta adrenergic selective blockers are atenolol, bisoprolol, betaxolol, celiprolol, esomolol, and metoprolol, as we know. And they decrease the SAN automaticity, they decrease the AV node automaticity, they decreases the ectopic ventricular or atrial automaticity, they decrease the early depolarization time, they decrease the delayed depolarization time induced trigger activity, and they reduces the SAN re-entry also. They also reduces the AVN conduction terminating re-entry also. So coming to class 2B. Class 2B, we have non-selective beta-adrenergic activators. The only drug in this is isoproterenol, and it also acts through G protein coupled receptors and increases the cyclic AMP and inflow, and decreases the RR and PR intervals. So there will be increased escape ventricular automaticity and suppression of bradycardia dependent early depolarization related trigger activity. Coming to class 2C. Class 2C are muscarinic M2 receptor inhibitors. These drugs are atropine, anisetamine, hyoscine, and scopolamine. So these causes the inhibition of supraventricular and muscarinic cholinergic receptors. So by supraventricular, these drugs acts on SA node, AV node, and atrial tissue also. Thus, it increases the SAN automaticity, increases the AVN conduction also, causing increase by this it increases the heart rate. These drugs increase the heart rate. Coming to class 2D. Class 2D are M2 receptor activators. So these contains activation of supraventricular M2 cholinergic receptors, which activates potassium acetylcholine channels, and these by thus hyperpolarizing the SA node, shortening the action potential durations, and in the atrial and AV node tissue. So thus it reduces the cyclic AMP inflow, thus therefore decreasing the inflow of the calcium, and also decreases the inflow of funny current into the SA node. So this inhibitory effects of adenyl cyclase and CMP activation, reducing the stimulatory effects of calcium, potassium, and chloride, and inhibitory baseline ITI adrenergically activated ventricular tissue also inhibits, and thus it causes the increased RR interval and PR intervals. The drugs that are included are digoxin, methaqualone, pilocarpine, and carbachol. So these drugs decreases the SAN automaticity and also decreases the sinoatrial node re-entry. They also reduce the AV node conduction, thus terminating the re-entry, just like class 2A. So class 2E. Coming to class 2E, these drugs are adenosine receptor activators. So these adenosine receptor, only two drugs are there. One is adenosine, second one is ATP. So these drugs acts on the supraventricular tissue, activate G protein coupled rectifying rectifying potassium currents, and it also hyperpolarizes the SA node and shortens the action potential duration in the atrial and avian tissues, and reduces the cyclic AMP, and therefore decreases the inflow of the calcium, decreases the funny current into the SA node, thus causing the decrease in the contractility and decreasing the heart rate. So thus it increases the RR interval and PR interval. So it primarily causes in simple lines, it causes the decrease in the SA node automaticity, decrease in the AV node conduction, and terminating the re-entry. There will be reduction in early depolarization and delayed depolarization induced trigger activity. Coming to class 3. Class 3 are potassium channel blockers and openers. In class 3A, we have voltage dependent potassium channel blockers. These are non-selective channel, in class 3A, these are non-selective potassium channel blockers. So in class 3A also, there is subclasses. The first class is non-selective potassium channel blockers. So block of multiple potassium channel targets resulting in prolonged atrial, Purkinje system, and ventricular myocyte AP recovery, increasing the ERP and reducing the repolarization reserve and prolonged QT intervals. So the drugs included are ambacillide, amiodarone, and dronedarone. So they increase the action potential recovery time, increase the refractory period with decreased re-entry tendency. So coming to class 3A, these are selective potassium channel blockers. Class 3 subclass, in class 3A, this is the second subclass. Again, we can call it subclass because class 3A is a subclass. So class 3A, the second subclass is HERJ channel mediating potassium blockers. These are rapid current potassium blockers. These causes prolonged atrial Purkinje and ventricular myocyte action potential recovery, increasing the ERP and reducing repolarization reserve and prolonged QT intervals. So the drugs included are dofetilide, ibutilide, and sotalol. So they increase the action potential recovery time, they increase the refractory period with decreased re-entry tendency. So coming to the third subclass of the class 3A, class 3, that is, these are potassium channel slow current blockers. So these prolongs the action potential in atrial, Purkinje, and ventricular myocyte recovery, action potential recovery, and increasing in the ERP and reduces the repolarization reserve and prolongs the QT interval. So there are no clinical drugs as of now that are approved by the FDA. So only the class is there. There are no drugs in this. So it increases the action potential recovery time and also increases the refractory period with decreased re-entry tendency. Just like class 3, all the class 3A potassium blockers. The only difference is between the channels, whether it's selective or non-selective, and which channel it is selecting. And the fourth subclass in class 3 is potassium channel ultra rapid current blockers. These prolong the action potential same as the class 3 other classes, increase the atrial action potential recovery, increase the ERP, reduces the repolarization reserve. The drug is vernaculant. These drugs have atrial specific actions which increase the action potential recovery time in atrium also, and also increases the refractory period and decreases the re-entry tendency. And class 3A, I think the fifth subclass is potassium channel mediated outward current blockers. So they prolong the atrial, Purkinje, ventricular myocyte action potential recovery, increase the ERP, and decrease the repolarization reserve, particularly in the subepicardial opposite to the subendocardial ventricular cardiomyocytes. So the location is different. So these drugs act only on the subepicardial cardiac myocyte, ventricular cardiac myocytes, and the drug is tedicimil. So it increases the same as other drugs, increase the action potential recovery time, increase the refractory period, and decrease the re-entry tendency. So coming to class 3B. So class 3B, we have potassium channel openers. These are metabolically dependent potassium channel openers, particularly inflow of potassium and ATP. These openers, they increase the inflow of potassium and ATP. So opening of ATP sensitive potassium channels, shortening the AP recovery, refractory, shortening the refractoriness, shortening the repolarization reserve of all cardiomyocytes, apart from synovial node, and this causes shortened QT intervals. The two drugs that are included in this group are nicorandil and pinacidil. They have the potential to decrease the action potential recovery time. So coming to the class 3C, these are transmitter dependent potassium channel blockers. These two are potassium acetylcholine inflow blockers. These transmitters GIRK1 and GIRK4. These are the proteins that are attached to these channels, and they inhibit the GI protein of beta gamma subunit mediated activation, and inhibits the potassium acetylcholine inflow, particularly in the SA node and AV node and the atrial cells, thus prolonging the action potential duration and the ERP and decreasing the repolarization reserve. The drug that is named, but not, the name is not given, that the code is given, that is BMS 914392 is the drug code. The name is not yet available. So the reduction in these class of drugs that only reduces the synovial node automaticity. So coming to class 4A, these are calcium handling modulators. These can be blockers or modulator. I mean, they can be blockers or enhancers also. So in class 4A, we have surface membrane calcium channel blockers. These are non-selective. These decreases the inflow of calcium, thereby resulting in inhibition of synovial node pacing, inhibition of AVN conduction, inhibition of increasing the ERP, increasing the AP action potential recovery time, increasing the refractory period, diminishing the repolarization reserve, and suppression of intracellular calcium signaling, and thus by increasing the PR intervals. The main drug is bepiridil. In this, there will be reduction in AV conduction, terminating the re-entry, and also reduction in the early after depolarization and delayed after depolarization triggered activity. So coming to, in class 4A, the second class is, these are selective calcium channel blockers. This is the second subclass. This is the selective calcium channel blockers. They act on these two channels, CAV, calcium channel 1.2 and 1.3, mediated by L-type calcium current. So they block the calcium current. They decrease the inflow of calcium into the cardiac myocyte, thereby resulting in decreasing in the synovial node pacing, inhibition of conduction of at AVN node, prolonging the ERP, increasing the recovery time, and increasing the refractory period, diminishing the repolarization reserve, and suppression of intracellular calcium signaling, thus by increasing the PR intervals. So these two, the drugs that are included are verapamil and diltiazem. Both of them are even in calcium channel blockers. These two are in same class, but in spite of that, their inherent chemical nature is different. Okay, so one is phenylalkylamine, one is benzodiazepine. So these two drugs also causes the reduction in the AV node conduction, and also terminates the re-entry and decreases the early after depolarization and delayed after depolarization reduced trigger activity. So class 4A, another subclass is, these are T-type calcium channel blockers. They also decreases the SA node pacing, prolongs the His-Purkinje phase for repolarization, and but these are absent in, these are not acting on ventricular cells. So class 4B, these are intracellular calcium channel blockers. These are sarcoplasmic reticulum pyridine receptor type 2 calcium channel blockers. They decreases the sarcoplasmic reticulum calcium release, reduces the cytosolic calcium and the sarcoplasmic reticulum calcium. So these two drugs are flecainide and propafenone. So these decreases the delayed after depolarization trigger activity, induced trigger activity. Yeah. So this another class 4B drug is IP3R calcium channel blockers. They act on atrial sites. They reduces the atrial calcium release from the sarcoplasmic reticulum inside the myocyte, and they reduces the cytosolic and sarcoplasmic reticulum calcium. But there are no drugs as of now. Still work is going on. There are no drugs in this class. So if I'm coming to class 4C, these are sarcoplasmic reticulum calcium ATPase activators. They increases the calcium ATPase activity, increases the calcium on the sarcoplasmic reticulum. They reduces the delayed after depolarization induced trigger activity. There are no clinically approved drugs in this class also. Coming to class 4B, these are surface membrane ion exchange inhibitors. They reduces the sodium calcium exchange and reduces the depolarization associated, thus by decreasing the subsarcolemmal calcium. There are no drugs in this class. There will be, they also proven to decrease the early after depolarization and delayed after depolarization induced trigger activity. So coming to class 4E, these are phosphokinase and phosphorylase inhibitors. So these are they increase or decrease the phosphorylation levels of the cytosolic calcium handling proteins. These act on calcium handling proteins, not on calcium channels. These include calcium MK2 modulators, and these are also they alters the calcium intracytosolic signaling and intracellular signaling. So there are no clinically approved drugs in this class also. They also, like all calcium channel blockers, decreases the early after depolarization and delayed after depolarization induced trigger activity. So coming to class 5, these are transient receptor potential channels blockers. These are transient receptor potential channel blockers. They also decrease the calcium signaling. The only drug that is under investigation is N-anthranilic acid. It also decreases the early after and delay after depolarization induced trigger activity. Coming to class 6, these are connexin blockers. The CX means connexin. It contains connexin 40, 43, 45. What are connexins? Connexins are the gap junctions that pass the depolarization from one cardiac myocyte to the other cardiac myocyte. They reduces this cell-to-cell coupling will be reduced, and the action potential propagation is also reduced. Coming to you have CX connection 40 in atria, AV node and ventricular conduction system, 43 in atria and ventricles and distal conduction system, and 45 in His bundles, SA node and AV node. So the blocker that is under investigation is carboxynolone, carbenoxynolone, and it decreases the reduction in ventricular and atrial conduction, decreases the accessory pathway conduction, and also decreases the AVN conduction. So class 7 are upstream target modulators. These are long-acting drugs. These drugs should be used for a longer time to improve the cardiac function in an already diseased cardiac tissue. So these in this subclass, the first subclass is angiotensin converting enzyme receptors. So these act on the electrophysiological and these act and remodel the cardiac tissue, whether it is fibrotic, hypertrophic, or inflammatory. The drugs are captopril, enrabinil, as you know, all the ACE inhibitors comes under this class, and they reduces the structural electrophysiological physiological remodeling changes that compromise AP conduction, and they increase the reentrant that compromise AP conduction and increase the reentrant tendency. So coming to the second subclass, the subclass is angiotensin receptor blockers. So ARBs. These also act same like ACE inhibitors, and the drugs, as you know, telmisartan, losartan, olmesartan, valsartan, and saprosartan. And coming to the other subclass of class 7 is omega-3 fatty acids. Omega-3 fatty acids, they also cause same. They also act in the same way as ARBs and AC inhibitors. And these omega-3 fatty acids include eicosapentaenoic acid, docosahexaenoic acid, and docosapentaenoic acid, as we know. And post-myocardial infarct reduction risk of cardiac death and myocardial infarct. It also decreases the, as I said, it acts on a long-term decrease in the abnormal cardiac rhythms. They are not short acting. They need time. They need more time to act on the myocardial tissue and remodel the tissue. So there will be reduction in structural electrophysiological remodeling changes, and also compromise the AP conduction and reentrant tendency, increasing reentrant tendency. Coming to the last class, this is the statins. All the statins coming to this class 7 subclass. So same as omega-3 fatty acids, all the actions are same. As I said, these statins also needs time to remodel the cardiac tissue which is already damaged. So as we see, this is the diagram where we can see only for class 1. This is the class 1. There is the as you can see here, all are these sodium channels. In this sodium channels, the class 1A, class 1B are they're causing depolarization, and this depolarization leading to opening of sodium channels. That's coming from the, and class 1C is acting in the intercellular level, and it's closing the sodium channels. So decreasing the sodium channels in the early stage causes decreasing the action potential conduction and increase the triggering threshold. Thereby, by decreasing the action potential conduction, it increases the arrhythmic substrate in the tissue, and it also decreases by increasing triggering threshold. It decreases the automaticity and decreases the early and delayed after depolarization. And in a delayed late sodium current, it also decreases the action potential duration, and it also triggers decreases the triggering of early and late depolarization currents and triggered activity, and it also decreases the so this I forgot to mention this this class 1A, 1B, and 1D, 1A and 1B and 1D, these cause decrease in the arrhythmic substrate for Brugada syndrome. That's the BRS. And for this, in this class 1C, in late current, it decreases the arrhythmic substrate for long QT syndrome. So this is the
DAD అంటే ఏంటి శేఖర్? అక్కడ Brugada syndrome, EAD, DAD అంటే ఏంటి నెక్స్ట్ దాంట్లో?
early after depolarization and delayed after depolarization. Sir.
Okay.
So this is the diagram depicting all the class of drugs that are acting that we discussed just now. So you can see the class 0 acting on the HCNs, class 1 acting on the sodium channels, class 3 acting on potassium channels, we missed class 2. Class 2 acting on G protein coupled receptors, class 5 acting on TRPs, and class 6 acting on connexins, and class 7 acting on stressors. So these class 6 have class 4 have extracellular on surface acting calciums, and also intracellular cytosolic calcium receptors also differentiated here, thereby decreasing the intracellular calcium mechanism, intracellular calcium excitation and everything. So this diagram particularly defines the how and when the and where the various drugs are. What we just discussed now, all the drugs are acting. So this long action potential that we are seeing here, the D, is the ventricular action, cardiac action potential, and the short one is the atrial action potential. If you can follow the color lines here, it specifies which channel is acting at what period and causing what. So you can see the first one, that is the late potassium inflow, late calcium inflow. It is acting in the phase 2 in both atrium and ventricle. In the sodium channels are acting in phase 1 in both atrium and ventricle. And this late sodium channels, this NCX, this is acting connections, these act on mid phase 2 or late phase 2 in both atrium and ventricles. Coming to this, below that we have all you can follow, everything is clear-cutly mentioned in this, at what phase what channel opens and what drug is acting on that channel. You know, you can see all the receptor names are given here. So these are, I already described which receptor is acted upon by which antiarrhythmic drug, so that it can cause its effect. So you can easily follow this. It's maybe it looks clumsy at the start, but it's very easy to follow, and we can understand this by following the colored lines and colored pattern. So multiple actions of cardiac arrhythmic drugs. So there are multiple actions for every drug, not for all drugs, but most of the drugs in this classification. As I said earlier, this is an extension of Miles, Swan, Williams, and Singh classification. So this classification is not a new classification. So that's why they kept, they mixed these two, they extended this Miles, Swan, Williams classification. For these antiarrhythmic actions, they just used class 1, class 2, class 0, and class 3, and class 4. They are not going for class 7, and they are not going till class 7. They are only pertain themselves to class 0, class 1, class 2, class 3, and class 4. This class 1, class 2, class 3, class 4, as we know, this is the old classification. So they are pertaining only to this. So as you can see, ivabradine, it acts on the inflow of the funny current. That's the main thing, that is ivabradine main channel that is acting on the that acts, but it also acts on the rapid potassium inflow antagonism. Coming to quinidine, it acts on multiple inflows of the potassium ATP, potassium, potassium slow, rapid, and intermediate current, and also on the transient current. So it also acts on the alpha-adrenergic and cholinergic actions, in addition to class 1A antagonism. So coming to diazepamide, it also acts on, except calcium, it acts on same like quinidine. It also have negative inotropic effect, but no alpha or beta adrenergic effects, as I told you earlier. So for same as for procainamide, it also acts on potassium inflow, whether it is late or rapid or potassium ATP mediated, and also acts on autonomic ganglion. Coming to lidocaine and mexiletine, I said there is no effect on potassium inflow for these drugs. Coming to flecainide, you have action in potassium, ultra rapid potassium inflow, rapid potassium inflow, calcium inflow, and Reiner type 2, Raynaudin type 2 receptors also in the sarcoplasmic reticulum. So coming to encanide, it also acts on the ultra rapid potassium inflow and rapid potassium inflow. And propafenone, it also acts on the same as flecainide. It also in addition to that, it also has beta adrenergic and vagal action, and ranolazine, potassium rapid current inflow mechanism, it also blocks it. And coming to beta blockers, the class 2 drugs, cartilol, it increases the nitric oxide protection. Carvedilol, it decreases the late calcium channel, and randon RYR2, that is randon receptor type 2 calcium channel, and it also decreases the alpha adrenergic action. Propranolol, it acts on sodium channels, as we know. Betoxolol, it also decreases the late calcium current. Celiprolol increases the nitric oxide protection, and it also partial beta adrenergic agonist, beta 2 adrenergic agonist, and weak alpha adrenergic antagonist. And nebivolol, it also increases the nitric oxide protection. So coming to the next drug, so dofetilide, it also considered as a pure rapid current, rapid inflow of potassium blocker. And ebutilide, it acts on sodium channels and inhibits the inflow current of the sodium. And sotalol, it acts on potassium also, you know that. And it also clophium, it also same as sotalol. And amiodarone, it acts on number of channels. It acts on sodium, potassium, calcium, and every channel, and it decreases the inflow. Dronedarone, it acts on the slow potassium current and also has beta 1 adrenergic action. And vernaculant, it also late sodium channels it acts, and tedosmil, it acts on rapid potassium inflow current and blocks it. And nicorandil, it has nitrate action, causing vasodilatation, as you know, the vascular smooth muscle. And these drugs, remarcalim and chromacalim, these are not defined in any class, but these also act in same as nicorandil. And verapamil, it acts on cardiac vascular smooth muscle and causes the effect tachycardia in addition to the calcium channel blocker. And diltiazem also, it also acts on the vascular smooth muscle. Bepiridil acts on the vascular smooth muscle and decreases the delayed after depolarization. So anti-arrhythmic actions of these drugs, as we know, what are the conditions where we can use these anti-arrhythmic drugs? Class 0, ivabradine, it is used in stable angina and chronic heart failure with heart rate of more than 70 beats per minute. And has potential new applications in all the tachyarrhythmias also. So coming to class 1A, supraventricular tachyarrhythmias, particularly recurrent atrial fibrillation, ventricular tachycardia, ventricular fibrillation, including short QT syndrome and Brugada syndrome. So coming to class 1B, lidocaine and mexiltine, as we know, ventricular tachyarrhythmias, fibrillation and tachycardia, and particularly after myocardial infarction. Propafenone and flecainide, supraventricular tachyarrhythmias, atrial flutter, fibrillation, sinus atrial tachycardia, and tachycardias involving accessory pathways also, like Wolff, Parkinson's, and White. And ventricular arrhythmias resistant to other treatment in the absence of structural heart disease, premature ventricular contraction, and catecholaminergic polymorphic ventricular tachycardia. These are all the things, these are all the conditions where we can use propafenone and flecainide. Ranolazine, as we know, the first and foremost is the stable angina, ventricular tachycardia, and other tachyarrhythmias are under study. Okay, coming to class 2 drugs, beta blockers, as we know, sinus tachycardia, all other types of tachycardia, and supraventricular, including supraventricular and ventricular tachycardias. So they can also be used for rate control in atrial fibrillation and ventricular arrhythmias. So atenolol, propranolol, and nadolol are also used in long QT syndrome. Nadolol used in catecholaminergic increase in the heart rate. It can be used in catecholamine heart rate due to catecholamine infusion. catecholaminic action. Nedlol can be used. Isoproterenol, it increases the ventricular escape rhythm, and in case of complete AV block, and before placing definitive pacemaker. And drug-related bradycardia, it can be used, and also drug-related bradycardia causing torsadipoitis. Coming to class 2C, as we can see, all the symptomatic sinus bradycardias, we can use atropine, hyacinth, scopolamine, and AV node conduction blocks, and vasovagal attacks, everything. And coming to class 2D, sinus tachycardia and supraventricular tachyarrhythmias. Class 2E, as we know, all AV node tachycardias and supraventricular tachycardias. And it also be used for differentiation of sinus from atrial tachycardia. Coming to class 3, in that I made this class 3.1, 0.2, 0.3. These are not given, but I made it because for easy understanding. These are all class 3 only. Particularly, amiodarone, dronedarone, ambicillide are used in ventricular tachycardia, as we know. Tachyarrhythmia causing by WPW syndrome, atrial fibrillation, with atrioventricular conduction accessory pathway, ventricular fibrillation, tachyarrhythmia associated with supraventricular arrhythmias and atrial fibrillation. So dofetilide, epitilide, and sotalol, they are used in patients with without structural heart disease or with remote myocardial infarction. Tachyarrhythmias caused by WPW syndrome, atrial fibrillation, same as class 3A. 0.1 by any accessory pathway, tachyarrhythmias associated with supraventricular arrhythmias and atrial fibrillation. Vernaculant, immediate conversion of atrial fibrillation. Prednisolone, acute conversion of atrial fibrillation. Nicorandil, in the treatment of stable angina as the second line of drug. Pinacidil, used as it is used in the treatment of hypertension, but it's still under investigation. The class 3C drug as used in, as of now, it is under study for the management of AF. So coming to class 4 drugs, bepiridine, angina pectoris, and potential management of supraventricular tachycardias. Class 4, verapamil and diflunism, supraventricular tachycardias and ventricular tachycardias without structural heart disease. And rate control in atrial fibrillation. Flecainide and propranolol, catecholinergic polymorphic ventricular tachycardia. So this is the clinical application. Coming to the class 7, class ARVs and ACIs, as we know, in hypertension, symptomatic heart failure, potential application in reducing arrhythmic substrate. They remodel the cardiac tissue. So omega-3 fatty acids and statins also, they also post myocardial infarct, reduction in risk of cardiac death, myocardial infarct, stroke, and also abnormal cardiac rhythms. They also used to control all this. Coming to pro-arrhythmic actions of antiarrhythmics. When we have antiarrhythmic action of a drug, we should suspect it has got a pro-arrhythmic action also. Coming to ivabradine, it causes sinus bradycardia because it acts on the sinus node. So quinidine, torsadipoitis, and with prolonged QT interval. And it also has the vagolytic effect, increase the ventricular rate in atrial flutter. So because of the early after depolarization related trigger activity and conduction slowing in the atrium and enhanced for unaltered atrioventricular conduction. So diazepam, it causes torsadipoitis or prolonged QT syndrome, and procainamide causes torsadipoitis and prolonged QT syndrome and ventricular tachycardia in presence of ischemic heart disease. So flecainide increases the ventricular rate in atrial flutter. Flecainide also causes ventricular tachycardia in presence of ischemic heart disease or old myocardial infarction. So propafenone, it increases the ventricular rate in atrial flutter and also increases the ventricular tachycardia in presence of ischemic heart disease or old myocardial infarction, just like flecainide. In addition to that, it also slows the sinus node by directly depressing the sinus node, just like ivabradine. Beta blockers. Sinus bradycardia, as we know, AV block, sinus tachycardia, and other tachycardia. Sinus bradycardia, AV block, because they depress the sinus node, just like ivabradine, they decrease the funny current they block the funny current, and sinus tachycardia because of the upregulation of the receptors with long-term therapy, and also decreases the and also causes the sinus tachycardia on beta blocker withdrawal because of the upregulation of the receptors. More number of beta blockers are available, beta receptors are available. So when you withdraw, it causes sinus tachycardia. So coming to isoproterenol, sinus tachycardia, increase the triggering activity by beta receptor activation. Carbocolin digoxin, sinus bradycardia, AV block, ventricular tachycardia because of the sinus node depression and decreasing the automaticity and AV node conduction, increasing the vagal tone, increasing the delayed after depolarization related trigger activity. So atropine exacerbate ventricular bradycardia and exacerbate effects of low atrioventricular block. So it increases the SA node automaticity and atrioventricular conduction despite persistent degenerative AV block at or below his bundle. So adenosine, sinus bradycardia, sinus arrest, and atrioventricular block. Because it depresses the sinus node automaticity and decreases the AV node conduction. And frequent atrial and premature ventricular beats and atrial fibrillation. The mechanism is still unknown for this. So coming to dofetilide, ebutilide, and sotalol, causality point is in prolonged QT syndrome, and by early after depolarization related trigger activity, and verapamil, sinus bradycardia, AV block, and increased ventricular rate in patients with atrial fibrillation with WPW syndrome. So it decreases the sinusoidal node automaticity and AV node conduction by blocking the calcium channel. So this completes the class. I think it's an extensive class, but thanks for bearing with me. Thank you.
Thank you, Shekhar. First of all, without Google, it takes a superhuman effect to remember all the new classes of drugs. But it's nicely put together. All the slides and all were very good. Too good. Okay. Anyone have any additional points and questions? Floor is open.
Shekhar, it was very nice. Nice to listen to, and it was difficult to understand at the same time.
Yes,
but do you have any flow chart, like, whenever we have some arrhythmias in the ICU or in the OR, do you have any flow chart so that we can follow immediately? Like,
Madam,
first they say that
I made I will show you. These are colored charts actually. So if you follow the color, you can see this. You can you can change it also. I made it personally, so we can change the colors also, so that it can be more visible directly. I mean, clearly visible.
Yeah. Okay. It is nice.
Yeah. Every drug has its own color and its own actions, and as in their clinical application, at the same time their adverse effects also are lined like in the same color.
Shekhar, good morning.
Good morning, sir.
What is the drug of choice for refractory tachyarrhythmias? And what is the drug of choice for re-entry tachycardia in WPW syndrome?
Drug of choice for WPW, it's more of either it's calcium channel blockers or beta blockers, sir. I think so, but drug of choice, I didn't go through the drug of choices. That's why I am a bit confused, actually.
For the first question, it is beryllium. You have not mentioned beryllium.
But beryllium is not included in this, sir.
And the second question, as you said, it is the verapamil.
Any experience of extra tachycardia?
Any other questions or suggestions?
డ్రగ్ డోస్ కూడా యాడ్ చేసేసే శేఖర్ టేబుల్ లో సరిపోతుంది.
But these are only classification. No, I am not going into the individual drugs.
Yeah, I know, I get it. But few major drugs, if you have the doses also, the table is very nice actually.
Yeah.
Thank you so much. But
Actually, we can make a PowerPoint only on drug doses also.
Yeah, we can make that also. Yeah.
Dr.
కానీ
Shekhar,
చాలా బాగుంది, నిజంగా చాలా బాగుంది.
Madam, చెప్పండి.
for nutshell, what are the injectables are available and what are the tablets? We can divide the injections and tablets, no? So immediately,
Okay.
what are the drugs you are
Yeah,
using
Yeah,
regularly?
in that way it will be very easy. OT లో కూడా పెట్టడానికి అన్నట్టు ఉంటుంది.
Ivabradine is a tablet. Ivabradine is a tablet. Quinidine, diacylpyramide, these are injections, I think. You can see, you can suggest me here if I am wrong.
So I have two experience of ventricular tachycardia. It's
Please,
not responding with the DC version. And so one patient have 60 shock and second patient I think was 30 or 35. Still patient fully conscious and ventilator because of that. Because that's where we are not intubated. We do FDR. Okay. So continuously VT shock, we are getting almost 24 hours. So I think there is maybe 30 or 35 shock.
I think you can see here, Ivabradine is a tablet.
All
these are injectables only. Renolozine is
going. Magnesium going, xylitol going, Padron going. Any other drug?
As somebody asked, digoxin is a tablet. All
Digoxin is
tablets.
injectable and the tablet also.
Yes. Injectable
all
also.
kinds of varieties are used. And after 24 hours, he responded all the drugs. And the later slowly, enough and
And most of the class 3 drugs also tablets only, and injectables also available. And Nicorandil is an injectable, and verapamil has some tablets and injectables also. And ACE inhibitors, ARBs, and all the class 7 are tablets only.
Madam, as per the latest guidelines, whether you are withholding telmisartan on the day of surgery or not?
As of now, we are continuing, sir.
Mm.
We are continuing ACE inhibitors and ARBs also.
in CP, I'm not using only Butalok only. Because all cases are PUD. So I'm using the EF of below 30%, so that's why I'm not using it. More than 30%.
Madam, not audible.
Now, okay, sir. Sir, it's okay, sir.
No, it's okay.
Sir, if EF 35% or 30%, figure as this function. That time, so morning I'm not I avoid all this drugs.
Okay.
If EF is normal or above 35, so LV is okay. That time I just continue the drug.
Okay.
And in morning, in the 8 o'clock drug, you can continue 6 o'clock. But afternoon drug, I'm not taking.
Very nice,
Beta
madam.
if beta blockers are going to continue beta blocker at the same with the
Good practical point we have to follow. Okay.
if heart rate less than 60 or 50, so I'm mentioning that here to start, if a heart rate less than 60, don't do a BP 100 or 100. The please inform, after that only you can do that. Like this and like.
Anything add?
Today we will close the session, madam.
Thank you, Shekhar. Thank you,
Thank you,
Srikanth.
Shekhar.
Thank you to all.
Thank you,
Thank
madam.
you.